Hey everyone, welcome back to the Healthy, Wealthy, and Smart podcast. I am your host, Dr. Karen Litzy, sorry, I'm going to start that over. I screwed up my own opening. All right, take two. Hey everybody, welcome to the Healthy, Wealthy, and Smart podcast. I'm your host, Dr. Karen Litzy, owner of Karen Litzy Physical Therapy, located in New York City. And today we are going to be talking about I ruptured my ACL. Should I have surgery? So we're talking about new research that's just come out on a decision aid for ACL ruptures for children and adolescent. And with me, I have two authors. I have the main author, Andrew Gamble, and I have my friend and probably most frequent guest, Evangelos Pappas, is back on the podcast. So before we get going, you guys, I'm going to just throw it over to you just to share a little bit about yourselves for the listeners, so they know who's talking when. So Andrew, why don't you go ahead and start?
Sure. Well, thanks firstly for having us on the podcast. Appreciate the invite. And so it's great to be able to talk about the decision aid that we've just put out. So a bit of background about myself. I've worked as a physiotherapist in Sydney, Australia for about 10 years, with some sports teams and mainly in private practice. And now doing my PhD at the University of Sydney, so which is now full-time with a little bit of teaching in the physiotherapy program as well. And so Evangelos was part of helping me get into research, as well as Dr. Josh Sadro, who couldn't join us today, unfortunately, with other commitments. And Dr. Marnie McKay was part of that, helping me to get into research as well. So about a year away from finishing my PhD, and yeah, grateful to be part of a great team of researchers.
Thank you, Evangelos.
Well, I'm a friend of the show, as you pointed out, Karen. So we do go a long way back when Karen and I were working at the clinic in Midtown Manhattan a long time ago. I then did a PhD at New York University. I'm a physical therapist myself, specializing in orthopedic and musculoskeletal injuries. And I did a PhD at New York University in orthopedic biomechanics on ACL injuries that we will be discussing today. So I have been researching ACL injuries for close to 25 years now. And I was an academic at Long Island University in Brooklyn for 11 years before making the big decision and moving down under in Australia at the University of Sydney for 8 years, where Andrew was one of my students, actually, when he was training to be a physical therapist. And for the last 3 years, I am at the University of Wollongong, just an hour and a half south of Sydney, where I am leading the academic side of a health precinct that the university is developing, but also continuing doing research on ACL injuries. So one of the wonderful things about the Australian universities and the opportunities that I've had to develop a team here is the opportunity to work like these really plastic young brains like Andrew and the other PhD students, and really pushing the envelope when it gets to ACL research.
Yeah, well, thank you both for being on the podcast. And Andrew, I think I'll throw it over to you first. So, can you talk about the why and the what of this decision aid? So, why was this important to research, and why is it important to get it out to parents, healthcare providers, and patients?
Sure. So I guess some previous work that we conducted, we looked at the online information available in terms of evidence-based information to help people following ACL rupture make decisions. And what we found was that almost 48% of these web pages that we looked at, so half of them didn't include non-surgical management or rehabilitation only as an option in terms of management. So what we identified was that overall, there was a lot of misleading information online in regards to the information that helps guide these decisions if people are using Google or web pages to search for information. And then what we found was particularly in children and adolescents, they have increasing rates of ACL ruptures, and there's increasing evidence showing that there's larger amounts of ACL reconstruction surgeries going on. And so we wanted to target this population as providing an evidence-based resource to help children and adolescents as well as their parents with health professionals make this decision.
And when we're talking, the population we're talking about, just so that everyone is clear, is that 18 and under?
Yeah, so the people that we interviewed in terms of getting feedback about this decision aid was under the age of 18. And then all the evidence we used in the decision aid was looking at people under 18 years old to really target that towards children and adolescents.
And one of the things, as I was reading through the paper, that, obviously I know, but I don't think a lot of general public, so maybe parents and the children or the patients don't know, is that there's not a whole lot of ACL research in this population, right? So how did that make it more challenging to create a decision aid?
Yeah, so I guess in terms of high quality evidence, so Evangelos might talk a little bit more about this, but there are randomized control trials for adults comparing non-surgical management or rehab only to ACL reconstruction. But there's no studies of this quality in children and adolescents. So that did present some challenges, as initially we considered including some of this information in the decision aid and interviewed participants about this to whether we include this. In the end, we decided not to include that information in our decision aid to try and avoid confusion for the relevancy for children and adolescents. So what we did was just put together the best available evidence, which was mainly drawn from a systematic review looking at children and adolescents, which was drawing together different studies and putting that together, including the return to pre-injury level of sport rates for the different options and presenting that. And then we made sure to clarify in the decision aid that this is low quality evidence, and making sure that was clear and part of the decision aid, and making sure that's transparent in terms of using this decision aid with a health professional. But we still thought it was important to show patients and parents that this is the best available information, so they know that that's what they're making the decision on.
Yeah, Evangelos, do you want to add anything to that?
Well, just to add that for the patients, for the adolescents and their parents, it is actually a jungle out there. There's a lot of information. Andrew has demonstrated before very clearly in a review of online information, available online information, that the quality of the information there and the accuracy is quite mixed. For example, things like ACL reconstruction, do an ACL reconstruction because it prevents knee osteoarthritis, which in the literature has been proven to be very wrong. As a matter of fact, if there is a relationship, is in the opposite direction. So you may be at a slightly higher risk of developing knee osteoarthritis if you had an ACL reconstruction. Yet this information is out there in some reputable sources. So what Andrew's research really adds into this space is a tool that an objective a patient can evaluate and be aware of their options. It's not going to tell them what to do, but that is a vast improvement compared to what is happening now. Because what is happening now is you see either a physical therapist or an orthopedic surgeon or another doctor, or speak to somebody else, and they give you information that is not always comprehensive. And then depending on how well they explain it and how convincing they are, you may decide on a certain pathway.
Right.
There is another clinical decision aid that has been developed for adults from Stephanie Philby and her group in Melbourne, and they have developed a very detailed website that, again, for adults, they can certainly find it. I think they'll find it very useful.
Yeah, and for me, what I'm hearing is it allows parents, children to have a more informed consent about what they decide to do. Because a lot of times when you go into the doctor's visits, if you're the child or the parent, you're worried, you're concerned, maybe you're not taking in the information as well as you should. And you don't know what questions to ask. Like, you don't know what you don't know, right? So I feel like this aid really helps people be a little more informed. So when they do go to the doctor, they have some questions on here they can ask. So it's just gathering more information, right?
Yeah, I think one of the things with the patient decision aid is trying to clarify values that are most important in terms of making the decision. And probably the biggest thing is trying to create realistic expectations. So there's research showing that in young athletes who undergo ACL reconstruction surgery, 84 to 91% of these people expect to return to their previous level of sport participation. And then we know from the evidence that this isn't the case. So it's trying to realign those expectations. So, potentially as well that children and adolescents aren't blaming themselves if they've followed a program with either option, that they've chosen rehab only or ACL surgery with following rehab after that, that it's not their fault that something's gone wrong necessarily. And even if they've followed the program that they've been given, and those expectations are set early on.
Yeah, expectation setting is so important. Do you find that ties to better outcomes if the patient is given realistic expectations in the beginning, and maybe better outcomes from like a patient satisfaction point of view?
Yeah,
There
I
is
guess
no
with the
research.
yeah,
Sorry,
sorry,
go
you
ahead,
go,
Andrew.
Evangelos.
That there is no research often the ACL world, at least no high quality evidence there. There is quite a bit of in other pathologies such as stroke, for example. There is more work that is being done there. But to me, it would make sense, obviously, if the patient he has been promised or led to believe that they will return to sports, and then they don't because their knee hurts or because it feels unstable, or even worse, because it re-ruptures. That would be extremely disappointing for the patient. And I think that's where we're failing, again, collectively as clinicians. So because these are difficult discussions to have. How do you tell a 16-year-old who had, multiple ACL injuries and knee injuries that maybe you should consider switching to biking and swimming? It is a very difficult discussion to have.
Yeah. And sometimes the answer is no. And as the clinician, it is not our job to force a patient to do something. Like in the end, it is their decision. If a child, their decision along with the parent, but it is their decision ultimately.
Or I had a patient who was going helicopter skiing after multiple ACL injuries. Again, as long we cannot make the decisions for them, as long as they are aware of the risks, then it is. I think that's all that we can provide. And at the moment, again, I need to reiterate: in the ACL world, we are not explaining the risks, particularly the long-term risks to our patients, very well.
Yeah, I find, and I don't know if you guys have seen this as well, when you were practicing, that after someone, or even if I see someone before they go in for surgery, after they come out, we'd have the conversation about osteoarthritis being a likely outcome down the road, and they are just, eyes go out of their head and they're like, what? Like, no one's told me this. I have a patient now who's on his 4th ACL reconstruction. Nobody told him.
Yeah, and hopefully the decision.
Go ahead.
Yeah, hopefully the decision aid can help prompt some of those discussions as well as is part of what hopefully we can provide with this resource.
And in the development, well, actually, can you talk a little bit about how you developed this resource? What went into the development? What sort of research went into the development of this?
Yeah, so I guess so in terms of the development process, so there's international sort of patient decision aid standards in terms of creating a patient decision aid. And so that's something that we use to guide the process. And then I guess it started with putting together a multidisciplinary team, which included physical therapists, an orthopedic surgeon, our psychology researchers, and decision science experts as part of our team, and which also included, people that had ruptured their ACL themselves as part of our team. And then what we did, we created a draft decision aid, which was reviewed by this team. And then we recruited participants to interview online and gain their feedback on this draft decision aid. And then after doing that, we would go and make changes to the decision aid. And this was sort of a cycle of different interviews and then refining the decision aid. And so, as mentioned before, we interviewed health professionals who manage ACL patients, as well as people under 18 years old who'd ruptured their ACL So if they were still under 18 years old, we interviewed them with their parent,
Mhm.
as well as people who are now older than 18. Majority of those interviews were conducted alone, which gave some interesting insights into what information they wish they knew about when they were younger as well.
Mhm.
Uh, so that gave some interesting sort of themes to helping put the decision aid together. And so overall, we conducted a total of 32 different interviews, and that was with people from 7 different countries, which was nice to get different perspectives from different healthcare systems and different experiences from those participants. And then following each interview, we used a questionnaire to give to participants to rate the decision aid that they'd seen, and then we put this data together in the paper that we published. And overall, it was rated as an acceptable tool to
Mhm.
use. And going forward, we want to be able to test this in clinical use as well.
Mhm. Yeah, so is that sort of qualitative data that allowed you to refine this? And
Mm.
as I was looking through or reading through, I loved some of the quotes that you put in there. Like, it would be wonderful to have had this handed out, female 40 parent. It was well thought out, nice and balanced. It's good. Male orthopedic surgeon. And then I really would suggest that you reconsider what you're doing.
Mm.
Which was like male orthopedic surgeon. I was like, well, that's got to be a punch in the gut. Like,
Yeah, I
so
mean,
when you get that feedback, how do you then take that and refine the aid?
yeah, so yeah, it was great to try and we wanted to present it in a balanced way and get both positive and negative feedback
Mm-hmm.
because although we sort of put this together on PowerPoint initially to start with, we're putting it out there to get feedback on that. And then we involved a graphic designer later on to try and fix up some of the design aspects of that
Mm-hmm.
and really just work on the content with the discussions we had. And yeah, it was some mixed feedback on different things. And yeah, that one quote you were talking about from the orthopedic surgeon, there was some strong views from different participants that we interviewed. But overall, we just wanted to look to gather that as well as part of the
Mm-hmm.
process. It's important to get different views and using them in creating the end product. And I think even some negative feedback, some of that was around using the adult data as well and sort of questioning about that. And so, that was all helpful in helping
Mm-hmm.
put that together as the final product. And I think just yeah, being open to gather this feedback, whatever it was, and yeah, taking that on board.
Yeah, I mean, all feedback is good, regardless, because it helps you refine the tool. Um, and the other thing that I'm really glad that you just mentioned is that you worked with a graphic designer because it makes a difference. Like, how important is the look of the guide when it comes to people being able to interact with it and being able to get from it what you intend them to get?
So yeah, I guess like I had to clarify sometimes that, I had just put this together on PowerPoint and, as a background of, worked as a physiotherapist, not a designer in terms of
Mm-hmm.
my training, but I think people appreciated the content that we put in there and we use that feedback to guide that refining process. And I think that the visual appeal to it was something that a lot of people like to comment on that as well. And different people like different types of graphs that we use. And at the
Mm-hmm.
end of the day, we use the team to try and make some of these decisions. And in some of the supplementary material, we presented a table of what feedback we didn't end up including and our reasons for why. But I think it's really important that the decision aid is something, particularly for children and adolescents, that they would actually like to look at and something that's appealing for them to read and something that's easy to understand. And that was important, particularly getting the adolescent input about, how it looks and
Mm-hmm.
some of the terminology we used as well.
Yeah,
I guess
it's oh,
one other point was just that yeah, even the wording about the risks and harms was something that was really interesting. So the adolescents and parents that we'd interviewed talked about making them precautions and potential harms, and something to try and educate them on risk rather than something that can scare them, to try and inform them about these things.
Yeah, I mean, design makes a difference, and being able to take the available data that we have and to take all that you got from your interviews and be able to simplify it so that it can be understood by a child. Right? That takes a lot of work. And I think people underestimate how difficult and time consuming that can be. There are people in this world, that's all they do for a living, is they help to simplify paperwork for people. So to be able to do that and put it into a pretty nice package that's pleasant to the eye and easy to read is a huge difference. Because if you just gave people, a PDF or a Word doc and just said, kind of categories, it wouldn't land. Does that make sense?
Yeah, I think it was really important to then involve people that would, potentially use this decision aid, or looking back in hindsight about what information they would have liked to have had themselves. And yeah, even including like dot points and key points at the end, and using visuals as well. Yeah, a lot of feedback was about trying to make it include more graphics as well, and even the return to sport rates to, include little people and the images there to try and make that easier to understand compared to, a line graph or other types of graphs as well.
Yeah, no, it definitely makes a big difference. Is there anything, as you were going through, did anything surprise you as you were building out this aid?
I guess, as you say, it was a long process. So in terms of the interviews, like out of every interview, you could get lots of little changes to make. And I think one of the things was trying to decide about what changes to implement, and some things were more obvious than others, and other things a little bit more controversial about deciding what to change. I think, yeah, the clinicians that we spoke to, some of them had varied opinions about, the involvement of other structures with the ACL being injured, and how that could potentially affect management decisions as well. But I guess that was sort of expected, in a way that you might get some strong opinions either way. And yeah, I guess the challenge was trying to draw this together in a balanced way.
And in particular, the meniscus.
Yeah, whether Evangelos, you want to touch on that, I guess in terms of children and adolescents, the evidence that we presented was that it is a little bit mixed in terms of systematic reviews in children and adolescents. So some papers will suggest that the evidence isn't good enough to make a recommendation either way in terms of what management's conducted, while others will suggest, that decision should be made within the first 12 weeks, in terms of looking at injury risk. And so we tried to make sure we covered that in terms of the uncertainty around that evidence as well.
Yeah.
And I think that's a good point here to highlight actually a couple of things. First of all, again, thank you, Karen, for helping us to spread the word on this, because a decision-making tool that it does not reach the patients and the parents is not of particular use. So it is an open access paper, the one that Andrew published, and we will be sending you the links for the people who are interested to have a read at it. And there is the simplified version too, so they don't have to go through all the different methodology. So that is important. The second thing is that the ACL injury is complicated. So obviously there's the patient values, there is the physical activity before the injury, there is the aspirations for reaching a certain physical activity level after the injury, but also the concomitant injuries. So, in ACL is frequently comes with other injuries, either the other ligaments, such as the medial collateral, or less frequently the lateral collateral ligament, but also quite frequently with cartilage issues and meniscal injuries. So yeah, well, when there is a if there is a repairable meniscal injury, that does change things to a certain extent. But also there are other injuries, such as the LCL, for example, that probably necessitate a very different treatment. Frequently nowadays, and that is different compared to when I started practicing as a physical therapist, the injuries that are combined ACL, MCL injuries are very frequently managed conservatively nowadays too, allowing the MCL to heal first, and then potentially, even if it does go down the path of an ACL reconstruction, the MCL has very good capacity to heal. But if I can just highlight a couple of other points here, Karen, because you started going back to your original question, I tore my ACL, do I need to have surgery? It has been, it is exciting times in this research space in the last few years. Andrew alluded to some of that, but there are RCTs in the adult population primarily, and as you would expect, there are three RCTs now. So there's the Canon trial, which is the longest one, 11-year follow-ups published. Then there is the Compare out of the Netherlands. The Canon trial is out of Scandinavia, and then there is the ACL SNAP out of the UK, which is the most recent one. And there are some commonalities in their findings that are actually surprisingly consistent. So one of them is between almost half, so 41 to 51% of the patients who are randomized into the conservative treatment group, they end up having surgery. And that, again, is key to remember, so for the physical therapists out there, so if you treat patients conservatively and half of them are actually having surgery, then that's pretty much the baseline, right? You're doing pretty much as expected, but also for the patient. So it is not uncommon for the patient to go down the conservative rehabilitation path and still not be happy with their knee, and then try to and decide to have surgery. Does not necessarily mean they'll be happier after they had the surgery, and that's not something you can reverse. So that is the other big question there. But that's important to remember that these statistics are actually surprisingly consistent there. The other consistent finding, and again, Andrew alluded to that before, is in terms of the expectations. So a very large percentage of them, and the ACL SNAP did a very good job with capturing that, expect to go back to a Tegner activity of 7 or higher. So the high level sports, cutting, jumping, and so on and so forth. The majority of them do not. Those who do return to sport, they're at the 4 or 5 Tegner scale. So they do more fitness level of activities that are safer for the knee. That goes back to our earlier discussion about patient expectations. And then the final finding out of these studies, and there is a bit of variability there between the Canon that pretty much found no difference between the two groups. So the conservative treatment group and the early ACL reconstruction group had practically identical results when you see them. Again, let's keep in mind that the conservative rehabilitation group consisted of half of the people there who had an ACL reconstruction. The findings were slightly, I would say, marginally better for ACL reconstruction in the Compare trial, and then a bit more promising in the ACL SNAP, which used the more chronic. Again, the populations were a bit different. The ACL SNAP used a bit more chronic patients. But again, when you look at the actual statistics, whatever bump you get, whatever benefit you get from the ACL reconstruction in terms of the effect size, it is pretty small. So, the clinical significance of these statistical findings has been questioned. And that's important for the patients to know, right? That, the difference between the two approaches in terms of the outcomes is not large. So it's not a clear winner here. But yeah, the patient expectations should be managed early on.
Yeah. Yeah. And it's a hard conversation to have, but I think clinicians should be having these conversations. Certainly physical therapists should be having these conversations with their patients, because oftentimes, maybe as a physical therapist, you don't want to step on the toes of the surgeon. So what advice do you have for physical therapists to enter into these conversations without the patient then thinking, well, they don't agree with the doctor, or they're trying to push one thing on us. And I'm sure there's nuances in how to have these conversations. So if you have any advice for us, please let me know.
Well,
And
I
go
guess,
first,
yeah,
Amy.
the decision aid hopefully can prompt, I guess, some backing behind some of the questions you might ask, whether that's with, the physical therapist or the orthopedic surgeon. And I guess ideally, you want to try and make these decisions with a team of health professionals. So you're getting some different opinions based on their experience as well. And then the decision aid can be a tool to try and hopefully increase the confidence to ask some of these, hard questions, that we've tried to put together based on evidence rather than, as a patient feeling like you're just challenging, a health professional that has experience in treating a lot of these injuries, and might give you more of the confidence to ask them. And on the final page of the decision aid, we've included questions to consider while talking to the health professional. And that was something that we gained a lot of positive feedback on with the interviews. And we looked at different questions to include or exclude, and yeah, overall got some really good feedback on that. And then there's a list there of questions that can be used to help prompt some of these shared decision making sort of methods in terms of making the best choice.
Yeah. Evangelos, anything to
Yeah,
add?
just that, the tool is at a minimum a conversation starter. And I think in that way, I think it's going to be proved to be quite effective. But also, let's keep in mind a couple of things. First of all, the person who does the treatment of choice is not always the best person to help you with the decision making process. And I had a discussion just earlier this week. I don't see the physical therapists being less qualified. They're knowledgeable physical therapists, particularly those who specialize, and they do see, quite a few knee injuries. Then they're probably just as knowledgeable and importantly objective about the information they provide as an orthopedic surgeon. Of course, then there is, the business aspect of things. So obviously, you don't want to you work together with orthopedic surgeons, and you want them to keep sending patients to you because you do a good job and you rehab them very well after they have the reconstruction. But I would think, and I have to say this, particularly with the newer generation of orthopedic surgeons, and I've seen that, I've been seeing that as an observation for quite some time now. They're very, very open to have these discussions. They're very open to have these discussions. I keep being surprised when I do refer patients to orthopedic surgeons for having an ACL injury, and they suggest to not jump into surgery right away and then do a trial of conservative treatment first. And that's what happens in some Scandinavian countries. So for 12 weeks initially, you are placed into a structured rehabilitation program, and then at the end of this program, you decide whether you want to continue and then attempt to regain some fitness activities, return to fitness activities on an ACL deficient knee, or whether at any point you would like to have a consultation with an orthopedic surgeon. So yeah, I think these are important things to remember. Again, this tool, hopefully it will facilitate these discussions.
And is there research to show that doing rehab prior to, like, let's say a 3-month rehab, 1 month, 2-month rehab stint prior to an ACL reconstruction, is there research to show that the outcomes might be better?
There is a bit of research on prehabilitation, particularly for knee replacements and hip replacement, but also a bit on ACL injuries. And it is beneficial, on a variety of different ways by educating the patient. And even for those who have decided to have the ACL reconstruction, there is the benefit of regaining strength, regaining range of motion. So the better these outcomes are when you go into surgery, the better they are after you come out of surgery. Right. So that is important to remember. But also that's a good time to educate your patient about what to expect after the surgery, instead of doing that when they're just coming out of anesthesia.
Right. When they're all looped up and they have no idea what's going on, and mom and dad are so worried, they're on the verge of tears. That is the best time to talk about expectations. I find that always works really, really well.
Exactly.
We actually had in the interviews, one parent mentioned that it's good to talk about the medication or pain relief that could be given even after surgery, because I think in one instance it wasn't sort of discussed, and then they weren't sure, what, medication was going to be given to their child after the surgery and that sort of thing as well.
Yeah. So I mean, I really appreciate the work that you put into this, because I think, number one, looking at like interviewing everyone and really understanding what people are thinking is a really great way to then create these tools to then put out into the public. So like I said, Evangelos had mentioned earlier, we'll have links so that people can download this very easily and quickly, regardless of what platform you're listening on now. You will be able to do this. But where is this located? What journal?
So it's published, as Evangelos said, it's an open access British medical journal. So yeah, it's freely available. And so the decision aid is available in the supplementary material of the article itself. So if people wanted to look through the article, they can do that. And then there's the link to the decision aid. So in the supplementary material, there's also that PowerPoint version of the decision aid as well.
Mm-hmm.
So being aware that there's that version as well as the final 4-page document that was the graphic designer helped put together. And then recently we've tried to make it even easier to access the decision aid as well. So at the Institute for Musculoskeletal Health, where I'm doing my PhD, we've got a couple of other decision aids that Dr. Josh Sadro as well has been involved in putting together. And so via their webpage, we can give people a link to try and access the decision aid as well.
Perfect. Yes. And again, like I said, regardless of what platform you're listening on, you'll be able to go into the show notes, and one click will take you to all of this information. Now, is there anything that we missed? Are there any points that you really want the listeners to take away from this conversation? Andrew, we'll start with you.
Yeah, I guess it would just be the key points that we put together. They sort of tried to bring together the feedback from the interviews. And one of the big themes was making sure psychological and social support was at least discussed or touched on in that early phase of the decision-making process with children and adolescents. That was something that was highlighted as potentially, often missed when people are looking back at their journey. And even there's some quotes about, how hard the mental side of it is in terms of rehabilitation, making the choice, and often it's such a quick moment that the ACL can be ruptured, and then you're forced into, making these decisions, and that's not easy, and it's having the support involved and planning for that, and that can be with family, friends, and health professional team, but making sure to, I guess, plan for that in the early stage is important. And then knowing that if you choose rehabilitation only, that you can always have delayed ACL reconstruction is important to consider. And then something that came out of the interviews as well was not always to rush. Sometimes there are pressure in terms of, more elite sport scholarships and different timing of the seasons to when to get back. But, important to consider the long-term outcomes of the knee rather than rushing to get back to sport, or at least considering the long-term outcomes. And I think the final thing would be to expect challenges in the journey of a lot of adolescents mention that it's dedication to exercise with either option, and expecting, I think there's a quote about that being a lifelong thing, that you're trying to plan for that as well, and try and make sure that children and adolescents understand, that priorities can change going forwards, and making sure what's important to them if it's returning to sport, that they're just aware of what the future might look like as well for their knee. So expecting the challenges, and I guess the main thing is to try and stay positive throughout the whole process as well.
Very hard to do.
Yeah.
Very challenging. Evangelos, how about you? What would you like the listeners to walk away with?
Yeah, well, the couple of things that we didn't have the opportunity yet to discuss in detail is that we spoke about the expectations. We concentrated on that today and how we were not doing a great job with that. But however, it's also important to highlight that surgery has come a long way. If you do have to have a reconstruction, then it is quite predictable, the recovery and the outcomes. A lot of patients go back to sports after it, whether that's the right thing or not. It really depends on the circumstances and the values of the patient. But if you do have surgery, make sure you choose a surgeon who's specialized, has a lot of experience. There is overwhelming evidence that the high volume centers, and there is a few in New York, but also all over the United States and the world, they produce better outcomes in terms of fewer infections, more predictable placement of the graft, fewer complications, and so on and so forth. And the other thing that probably deserves its own show at some point, Karen, is the ACL cross brace protocol, speaking about conservative treatment for ACLs, and that we're not going to go into too much detail, but it has been developed here in Sydney, and now a group at the University of Melbourne, again led by Stephanie Filbay, have published a paper recently with quite promising outcomes. Again, we still have to wait for the longer term studies and see what percentage of patients would benefit from something like that. But they have pretty strong radiological evidence at this point that following a protocol that is pretty rigorous, so it does require 90-degree flexion in a brace for a month, 60-degree flexion in a brace for another month. So the patients are on DVT prophylaxis during that time, and then gradually allowing further extension. They have demonstrated very promising outcomes at this very early stage. I had two patients that I referred to them, and both of them have very good outcomes so far with some evidence of healing of the ACL. So the next time I'll be back, which probably is not going to be too long from now, Karen, hopefully we'll have more long-term studies on this.
Perfect. That sounds great. Deal. Now, if people want to find you, if they have questions, where can they find you? Where can they reach you?
So I guess to reach me, like in terms of happy to, answer any questions on the decision aid. So my details are in the paper as well. If people are wanting to contact me, and then via Twitter as well, people can look at Andrew Gam as well. There I can provide those details as well.
Perfect. Evangelos?
On Twitter, I'm at EV Pappas with double P, P-A-P-P-A-S. But the good thing about having a name like Evangelos Pappas is that if you Google me, if you Google my name, then that will take you straight into my University of Wollongong website that has all the information there, including my email. I would love to hear from people who either have experience with using the tool. We're very, very open on feedback. And this tool, and again, that's something that we really need to highlight. That's not the end of it. It's not that Andrew published the paper, he'll get his PhD hopefully
now you're
soon.
all done.
That time you're all done, we'll forget about it. It is a living document, and we expect as more research is coming out, it's going to improve, further develop. We really welcome feedback from patients and from clinicians about it.
Yeah, that sounds great. And before we end, last question. Evangelos knows what this last question is, I think, because I ask everyone. So Evangelos, I'll start with you to give Andrew a little time to think on it. But knowing where you are now in your life and your career, what advice would you give to your 20-year-old self?
Career-wise only. Yeah, well, I forgot what I answered before, but I think just relax and enjoy the ride because things will work out at the end. Again, I, as a 20-year-old, I was, second year at physical therapy school. I was completely lost, had no confidence at all. And I think that's normal at this stage, but that does create its own stress and anxieties. And of course, there's all these options. Do I want to specialize in pediatrics? I love working with children with cerebral palsy. Do I want to go work with a sports team and travel? travel with them, but there's so many options. We do have a wonderful profession as physical therapists. We do work in a domain where, it's not just a paycheck for us. I haven't met any clinician who does this just to pay the bills. The goal there, and there should be a higher calling for us that is treating patients and particularly helping them during some of the most vulnerable times and reducing disability and so on and so forth. And that, as a 20-year-old, that got lost, that eventually things will work out and I will really love and enjoy my profession, but also an opportunity to thank you, Karen, for everything that you do, through the Healthy, Wealthy, and Smart show for all these years, not only for the profession of physical therapy, but also primarily for the patients, because, you were one of the pioneers who decided that these papers that are published and not everybody understands, and, they frequently put you to sleep. There's information there that needs to get out. And if we present it in the right way, then the broader audience and the patients will actually benefit from it. So your impact has been fantastic. So thank you for this.
Well, thank you. Andrew, how about you? What advice would you give to your 20-year-old self?
It's tough
just
to
a couple
follow.
of years ago.
Yeah, wasn't.
Should I
it's still
say
a little
14?
while ago now. Yeah, I guess I was just starting, like almost finishing, my master's as a physio at that age, and hard to follow on from Evangelos there, and sort of echo what he's saying in regards to, helping to get the evidence out there. You're doing a good job, Karen, on doing that. I think that's important. And what I've seen in research, I think one of the challenges is, putting together this work and then it's trying to distribute it as well, and making sure, that it can potentially make a difference and help someone as well. So I guess thinking of, my 20-year-old self, I think I would try and reassure myself, and say that, the work you're trying to do, that I was, I guess, involved in trying to learn and listen to other physiotherapists at that time, and wasn't quite sure where I would end up. I would try and reassure myself that, that hard work in trying to learn and continuing to taking an interest in physio can lead to opportunities. And as I said, I'm grateful to be involved in research now, and that's not something that I thought I would be doing when I was 20, coming out as a physiotherapist. So I think it would just be, following the process and keeping that interest, and making sure that, you're doing these things to try and help people at the end of the day, and that sort of pays off as you keep going through that process.
I think that's great advice. So Evangelos, Andrew, thank you so much for being on the podcast. I appreciate your time and our vast time difference at the moment. So thank you so much for coming on. And
thank you, Karen, for having us.
Of course, of course. And everyone, thank you so much for tuning in. Have a great couple of days and stay healthy, wealthy, and smart.